So today I'm going to talk to you for about 15 minutes about arthroscopic surgery for degenerative knee disease. And this is what it looks like. A colleague of mine, Raine Sihvonen, is here in the picture. I will first take you back to year 2000 and tell you how the scenery looked at the time. So conventional wisdom dictated that degenerative lesions about the knee, many controlled degeneration and meniscal tears were causing knee pain and impaired knee function. It was even believed that meniscal tears could potentially accelerate knee degeneration or OA due to wearing down knee cartilage. It was actually even proposed that there is this kind of a windshield wiper effect where torn pieces of meniscus would eventually wear down the cartilage, knee cartilage. And what about arthroscopic knee surgery? And when I'm referring to arthroscopic knee surgery, I'm talking about two procedures, debridement or partial meniscectomy or arthroscopic partial meniscectomy, APM. They were both considered effective in relieving knee pain, improving function, and slowing down progression of knee OA, to the point that this was the most common orthopedic surgery in the world. At least 2 million these kinds of procedures were carried out around the world. And most commonly, I'd say about 90% of the times, they were performed to treat knee pain attributed to a degenerative meniscus tear or other type of knee degeneration. In this 15 minutes, I'll try to fast forward you to year 2020 and how the scenery looks now. So all of this saga is a prime example of a bioplausible theory. Just to give you a little background on what I mean by this, in the early 1950s, 60s, surgeons, or even before that, surgeons realized that when a young person, typically a young person, twists or has some kind of a knee injury, sometimes the knee locks. Is very painful. The patient is unable to practically move the knee, especially extend the knee. And when they open those knees up, they realize that there is a certain type of a tear, which is called pocket handle tear, that once it was removed, the patient basically would regain the mobility and the pain was gone. They even developed different kinds of knives to make this procedure of removing menisci more convenient. To the point, this procedure was considered so beneficial that these kinds of procedures were carried out as preventive procedures for professional football players in the off-season. Once arthroscopy was really introduced, and especially with the introduction of MRI as a non-invasive means to diagnose pathology within the knee, all of a sudden we had a non-invasive specific diagnosis and even less invasive surgery, and all of a sudden the business just took off. What actually happened was a phenomenon called indication creep. The patient had knee pain, an MRI showing something that looked like a tear, something that didn't look like the meniscus was intact anymore, and all of a sudden we had an indication for surgery. Just to highlight you why I'm talking that the indication crept. These are all procedures, all knee arthroscopies carried out in Finland between 1997 and 2012. So within a 15-year period, almost 300,000 knee scopes were carried out. And of these 300,000 procedures, 90% were carried on patients with a diagnosis of knee osteoarthritis or degenerative meniscus. And only 10% were carried out on patients that had a true trauma. So what is the evidence? We are approaching 2020, and I'll try to guide you through the path. I would argue that most of you, if not all, know this study, because this is probably a single study that has changed orthopedic practice more than any other study. A randomized control trial, probably the first ever randomized control trial in orthopedics on arthroscopic surgery for knee OA. 3 groups, very quickly: debridement, lavage, and placebo, or just skin incisions. As most of you probably know, there was absolutely no difference between the 3 groups. If anything, placebo seemed best. A few years later, Canadian researchers pretty much confirmed the finding that arthroscopic surgery doesn't add anything or isn't more beneficial than conservative treatment in the form of exercise therapy. So this was for patients with established knee OA. So the question that remained, really, what about patients with less advanced OA or just a meniscal tear? And there are a lot of studies on this issue. I will, for the sake of time, I will just highlight the one that I've been involved in. And this is called the Fidelity trial that we published about 7 years ago. And it is a multi-center, randomized, double-blind, sham surgery controlled efficacy trial comparing APM to sham surgery. 3 primary outcomes assessed at 12 months. And here are the primary outcomes. The Lewis-Holmes score on knee function, and as you can appreciate, APM proved very effective in relieving pain. The only problem was that there was absolutely no difference between the APM and the placebo surgery groups. Another knee functional score, the WOMET score, a more specific meniscus specific score. Again, no difference between the groups. And this is the score on, this is a knee pain after exercise. And as you can appreciate, there was absolutely no difference between the groups. As I said, I only showed you the Fidelity trial. These are some of the studies that have been published on this topic. And this is just to highlight that there are currently about 10 randomized controlled high quality, low risk of bias trials, all convincingly shown that APM or arthroscopic surgery is not more beneficial than exercise therapy or sham or placebo surgery. So this is where we stand at the moment, year 2020. Abundance of evidence to question the link between degenerative lesions and knee pain and or impaired knee function, and more importantly, at least for us surgeons, at least 10 low risk of bias RCTs, all convincingly shown that surgery is not more beneficial than exercise therapy or sham surgery in relieving knee pain or improving function. But this is the short term. As I was asked to talk about the long-term things, I will cover them, but only after I will share with you a few more slides on the short-term results. Because of course, when one of the most common orthopedic procedures is questioned, there is bound to be a lot of critique and concerns about the quality of the studies and allegations that there would be subgroups that benefit from surgery. One of the subgroups to benefit from surgery has been argued to be those with mechanical symptoms. And again, another very bioplausible theory: if you have a situation like this, then quite intuitively, if you go and remove this piece of cartilage that cannot do anything except be beneficial. Sorry about that. Let's move on. Luckily, we were able to use the data from the Fidelity trial to assess whether or not this bioplausible theory would be correct. And this is how the Fidelity population looked at baseline. This is the APM group, this is the sham group. As you can appreciate, at baseline, approximately half of patients in both groups had or complained of mechanical symptoms. This is how the things looked at 2 months. This is how they looked at 6 months, and this is how things looked at 12 months. And I probably do not have to say anything more about this, how beneficial or how effective the procedure is in relieving mechanical symptoms. Just to show you that I'm not picking berries, rather just showing in the interest of time some of the key findings. This is another study by my Danish colleagues, or our Danish colleagues, and Stefan involved about 650 consecutive patients, prospective cohort, comparing patient-reported mechanical symptoms to presence or absence of a meniscal tear, and there was no difference between those with and without a meniscal tear. So it appears that mechanical symptoms are very loosely related to mechanical symptoms in these patients with degenerative changes. Again, this was not the only argument presented for the surgery. Another very commonly heard indication for surgery: I only operate those with traumatic tears. We have Stefan and his group thank for this study. The same population, they decided to compare those who had a traumatic onset of symptoms to those who had a less traumatic or degenerative onset of symptoms. And as you can appreciate, if anything, patients with a traumatic onset of symptoms and with degenerative knee disease do not benefit from surgery more than those with a less acute onset of symptoms. Of course, we still hear people saying that, but I can identify those that benefit from APM. And sorry to say, but orthopedic surgeons have reinvented the Cochrane's hierarchy of evidence. On top of all other studies is this one, I just know. So that is the highest level of evidence in at least in old orthopedic hierarchy. Unfortunately, it doesn't seem to apply to this particular case. Can orthopedic surgeons pick the ones that benefit from APM? This is another study by Stefan's group. Sorry about that. Let me go back. Despite combining a large number of preoperative factors presumed clinically relevant, change in patient-reported outcome 1 year following meniscal surgery was not predictable. And just to corroborate this, this is another study based on the ESCAPE trial that was published in the JAMA. Just last year, the authors published, so these are surgeons doing research on surgeons. They used the actual cases from the ESCAPE trial, presented them to surgeons and asked them whether or not this patient is going to benefit from surgery. So 194 predictions, and overall 50% of the predictions were correct, which equals the proportion expected by chance or flip of the coin. So surgeons were not worse at predicting who will benefit from surgery than by flipping a coin. As many of you might know, this is something that has resulted even the big journals to react on this. This is the BMJ that has published a very prestigious rapid recommendation clinical practice guideline. that first makes a strong recommendation against the use of arthroscopy in nearly all patients with degenerative knee disease, and even further goes to saying that healthcare administrators and funders should or may use the number of arthroscopies performed in patients with degenerative knee disease as an indication of poor quality care. So this is now where we stand. But as I said, I was asked to briefly review the long-term outcomes of APM. So just a few words about the long-term outcomes. First, about knee function and pain. So far, we have 3 trials that have completed 5-year follow-up. The METEOR trial from Boston, the trial from Goffin and Quist from Linköping, Sweden, and our trial. And all together, these trials very convincingly show that arthroscopic knee surgery provides no benefit over exercise therapy or placebo surgery in patients with degenerative knee disease. What about progression of knee OA? As you may recall, I started by saying that in 2000, people still believed that meniscal tear could actually accelerate the progression of knee OA. Since then, there have been quite a bit of epidemiological data to suggest that actually arthroscopic surgery is associated with increased risk of radiographic OA and also increased risk of, of having to undergo arthroplasty. I may add here, and I think I have to add here, that due to confounding by indication, this is of course very indirect evidence. How about direct RCT evidence? Let's go back to these 3 trials that I already briefly described. Altogether, these 3 trials show that there seems to be an increase in the risk of progressing of knee OA versus surgery versus exercise therapy or placebo surgery in patients with degenerative meniscus, degenerative knee disease. So I've now very quickly, and my apologies for that, I have now reviewed the evidence. This is a 20-year span. I'd like to say that this has been quite a piece for some of us to swallow, but in 20 years, the evidence has completely wiped out one of the most common, if not the most common, orthopedic surgery. We have both abundance of low risk of bias RCTs to show that it is ineffective, and also data emerging to suggest that this procedure is not only futile, but it could be harmful. Thank you very much for your attention. If you now, Stefan, have any questions, I'm happy to try and answer.
Thank you very much, Teppo. That was an excellent and comprehensive review of what we know about the effect, or rather lack of effect, of arthroscopic surgery for this particular condition. And we invite the participants to enter their questions and comments into the chat function. While you do that, one of the things that continues to surprise me is how difficult it seems to be to convince our orthopedic colleagues of this evidence, because we've essentially known this for now, I would say, about 10 years. Following the initial pioneering trial by Moseley in 2002, there were 3 or 4 trials published within a few years. So by 2010 or somewhere around there, we already knew what the situation or what the evidence was. And since then, it hasn't really changed. But it's been really hard to convince our colleagues to actually decrease appreciably their use of this particular procedure. So how do we go about implementing these findings? And what's your experience from Finland, for example, Teppo?
Thanks, Stefan. An excellent question. I mean, yeah, we actually just published a paper in the British Journal of Sports Medicine, an editorial that first of all highlights that what we have experienced here is about a 60 to 70% reduction in the number of knee and shoulder arthroscopies. As you well know, shoulder arthroscopies, or a certain procedure called subacromial decompression surgery, has been, the evidence for or against the surgery is equally convincing. So, so the first response to your question is that we are seeing at some parts of the world, we are seeing people responding appropriately. We are observing, but I mean, this is just like Max Planck said 150 years ago, that science advances one funeral at a time. So I'm sorry to say, but it seems like these changes, medical reversals, as one may call them, are painstaking. It's not a big deal that you've done something for 20 years and you have really truly believed that you are helping these people, and it turns out to be futile. And I mean, for some people, it seems to be more difficult psychologically to accept that. These are entrenched issues. These are entrenched beliefs. And when on top of that, you put money. I mean, for some people, this is their income at stake. What is encouraging to me is that the paper we published actually shows that the implementation that started to take place in 2007 for knee arthroscopy and in 2009 for shoulder arthroscopy first started in the public sector in Finland. But we do have a private sector here in Finland. But I mean, I think it has to do with somehow people accepting and realizing that I guess, if I have to guess, the paper was exactly about this, what happened. But when it also happened in the private sector, I think it might have something to do with people realizing, what's my legacy? Am I going to leave the stage so that I can hear, when I turn around, I can hear people laughing?
Yes, but I think that's...
This is my guess, but I mean, because this is, I mean, Stefan, the evidence is so overwhelming that this is basically what's going to happen. And I've asked a few of my old friends. The funny thing is that you can lose a friend by publishing a wrong study, or a study that has a wrong outcome. But I've told a few of my friends that, do you really believe that your residents are going to continue this show? Hell no.
I think there is one other aspect to this. We're of course speaking of our orthopedic colleagues now, both Teppo and I, but I also think we need to look at, let's say, the primary care, family doctors, and tell them that this is not the right thing when a patient comes in and complains of knee pain and may have some minor injury a few months back playing with the kids in the backyard or something, middle-aged or older. this is not, you know, about arthroscopic surgery, and an MRI is not the right thing to do either, because if you do an MRI in that population, you will find a meniscal tear. And if you have a patient in your office who knows he's got a meniscal tear, or she, and knows that that, you know, you have knee pain, well, it's very hard to convince that patient that, you know, this may not be connected. So don't invest money in that MRI in these patients, but send them to the physio and get them to do a good exercise program for a few months, and then, you know, take them back and talk to them and find out how they are. I think that's one additional way in which you can decrease the demand for these procedures. And of course, talk to the insurers and the administrators. We have one comment, I think, from Jos Runhar, who is asking whether you've considered to collect individual patient data out of these trials to do well-powered subgroup analyses.
Yeah, that's a wonderful question, and I had a chance to listen to the previous session and how beautifully people are collaborating and using the same data. Yeah, I've been approached and I've considered it. The problem we have with the fidelity is that it was started in 2007 when data sharing wasn't a norm like it is today. And to put it simply, we didn't ask the patient specifically, can we share the data? And to revise that informed consent at this phase, with all the problems of one declining and then not being able to use the complete set. So I'm kind of, we will do it, but we will do it only after we have collected, we have finalized the final data collection, and then we will ask them collectively, can we share the data with other people? But with the legislative changes and the GDPR, it's a nightmare. So yep. For now, fidelity data remains here. My apologies.
So this is actually one important piece of advice you're giving to those who are considering studies of this kind. Make sure that you get the patient permission to share their data for future research, collaborative research projects. You may need to get ethics permission to share them anyway, but at least then you have the patient's written permission to do so if in the future you want to do that. And with regards to your specific question, yes, I think there is actually an initiative now to try to collect data from these different trials and to do an individual patient data subgroup analysis, which I think would be an important additional study to do to possibly identify any subgroups that may benefit from the procedure. Thank you very much, Teppo. This was very informative, very helpful, excellent presentation.